Martin, let's talk about molecular testing maybe in a more of a community setting. So, it's easy for a lot of us who work at academic centers to say, oh, we have reflexive testing, and we usually get results back really quickly. But in reality, we know most patients are treated in the community, and it's not necessarily very straightforward. Patients may be getting biopsies at other institutions before they come to see you. It's unclear whether they've even had the molecular testing ordered. What are some of the barriers and challenges you've seen in some of the patients that you're treating in terms of those results being available, in terms of the NGS even being ordered?
Yeah, I think that's a big problem. We're getting patients through many referral channels, so there's not one good structured way and not one contact person in pathology that we can work with. So it's sometimes a dozen hospitals or more that provide biopsies for our patients that are being referred for management. I think that makes the value of liquid biopsy even higher. We are less in charge of tissue, and we oftentimes have to depend on the individual practices. So what Stephen was alluding to, that we are getting involved in tissue stewardship and the conservation of tissue for molecular testing as a priority. That's very difficult to do if you have no working relationship with the pathologists and the interventionalists that are procuring and processing the tissue. So for us, this poses a frequent challenge. We see a fair amount, about 1 in 4, quantity not sufficient tissues, and also a need for rebiopsy. And there are some things we can learn from liquid biopsy, but we've talked a lot about DNA and RNA, but we're also evolving into an era of antibody-drug conjugates where immunohistochemistries are becoming more and more important again, and certainly require more and more tissue. So unfortunately, oftentimes when a patient comes to me, we obtain a liquid biopsy with a preliminary diagnosis of cancer, but we oftentimes set up a concurrent repeat tissue biopsy to procure enough tissue to allow us to give the patient the full spectrum of opportunities for treatment. So it's really challenging, and unfortunately there's not a good way to harmonize it. My ideal scenario would be that the interventionalist has in mind that this is a lung cancer based on the radiographic impression, communicates with the pathologist to obtain NGS testing. We need it now in the early and late line setting, so we don't really have inappropriate stage anymore for disease sequencing or disease genotyping. So in my opinion, we should develop broader protocols that are applicable, similar like we do in other cancer types where reflexive markers are obtained. I understand it's more sophisticated in lung cancer with NGS as a baseline requirement, but we need all biomarkers up front. So whatever we can do to get patients to those results and therefore for treatment faster is what we need to do.
Yeah, and I think, Martin, you hit on also the IHC testing, and so we know that we have a recent approval for Teliso-V, the antibody-drug conjugate, for patients who have high MET expression, and this is 3+ on IHC testing. And so how are we going to incorporate now IHC testing on top of NGS testing for our patients? Eric, thoughts?
Yeah, I think it's really tough, to be honest, right? You just alluded to the quantity insufficient for a lot of patients, right? And every test we do is more tissue. Tissue is the issue for a lot of these tests, unfortunately, and we struggle with that amount. That being said, this is a biomarker. It's a new biomarker that we should be testing for. It's another option for patients. So the study that you're alluding to showed almost a 40+% rate of response in some of these patients. So that's really impressive to be able to offer that to patients. So if we don't test, we won't know, and then they may not have that option.